It is 12:02 Saturday afternoon, Dr. Payne Show. It is 416-870-6400, star 640 on your cell. You have questions, concerns about your health, bring them on. We'd love to talk to you. From head to toe, we cover it all. And what do you want to talk about today after your week? Why are you laughing?
Head to toe. It's just funny. I don't know why.
You've been drinking this morning, Luigi? Right.
No.
Wow, you really found that funny.
Yeah, I don't know why.
Right,
and
good.
you've said it before. So, let's start with a very, very common thing that all of us hear of all the time is sciatica. We always hear this term. I've got sciatica. Yeah. So sciatica in general just means leg pain. There's also a nerve in the leg called the sciatic nerve, which is what that term is often reserved for in layman's terms, where people say, I have sciatica, which often means an irritation of the sciatic nerve. In understanding the anatomy of the sciatic nerve, it's made up of the lower lumbar segments and some of the sacral nerve segments, and it then travels down the back of the leg. So oftentimes people who have pain down the back of their legs in the thigh area or down into the calf will say, I have sciatica, which is not necessarily wrong. But a lot of the times people exclude the fact that they may have nerve pain if it's in the front. Now, you can also have, there's other nerves. The other big nerve that supplies the front of the leg is called the femoral nerve. And it can mimic symptoms of sciatica just in the front of the leg. So it's simply there's a nerve entrapment somewhere. So whether the entrapment is the sciatic nerve or the femoral nerve, now the the sciatic nerve tends to be much more common again because it's lower down, and that's more likely where things tend to happen. But a lot of people have weird pain in the front of their legs on the lateral side or the outside part of their thigh, in the form of numbness, tingling, weakness, weird sensations. When someone comes in to me, and the reason why I'm bringing this up is yesterday I had a patient with an issue in the the front part of the thigh, and he was saying, no, my doctor told me it's not sciatica, so he was pretty confident it wasn't a nerve. And I had to explain to him, well, it's not the sciatic nerve, but you do have an issue going on with the femoral nerve, which is, again, another nerve that just supplies a different part of the leg. And so very, very similar in that, people who have sciatica can often complain of numbness, tingling, weakness, those types of things. But again, the pattern is characteristic where it's down the back of the leg. Femoral nerve issues are usually down the front of the leg into the thigh and the shin area and maybe the top of the foot. So again, not as common, but a lot of people do have leg pain in the front, and they just kind of dismiss it because they'll go on Google and they'll type things in and they'll often read, sciatica is at the back of the leg. So this isn't
Google
sciatica.
Med School.
Yeah. But that doesn't mean you don't have a nerve irritation. And nerves are, one of the conversations that I often have with people who have a nerve issue is nerve tissue does not heal very well. And we can all appreciate that because we've all heard of cases of paralysis through spinal cords being severed. We really have no way of healing that. If we have a scratch on our skin tends to regenerate really well. Even some other bodily
muscle
tissue.
fiber, great.
It can all, there's some things are better than others, but definitely probably the worst is nerve tissue. Once nerve tissue is damaged, it doesn't really regenerate. And so even with a quick insult, an acute insult to a nerve, could take 6 to 8 weeks to heal. And if you have sustained pressure on a nerve for a long period of time, how long could that potentially take to heal? So that's why it's very, very important to figure out what is causing. So if we just use the example of sciatica, which we've talked about a lot, it's very, very important to determine sciatica is just is a sign more than it is anything.
It's like saying fever.
Correct.
Right?
Let's figure out what's causing the pressure on that sciatic nerve, because if we can figure out what's causing the pressure on the sciatic nerve or the irritation of the sciatic nerve, that's what you treat, and that's where you have your best chance of eliminating this. In this gentleman's case that I saw yesterday, and he had pain and numbness and tingling in the front of his leg, what we were able to find is that he has likely femoral nerve irritation just in the muscles, the quadratus lumborum and the psoas, where the femoral nerve actually has to pass through those muscles. And so now I've basically recommended to him to go get some therapy to release those muscles, and I do believe he will get better. But he's had pressure on this nerve now for about 2 months. So can we expect that all of it will be gone overnight or over 2 or 3 treatments? Likely not. Again, nerve tissue takes much longer to regenerate, to heal, if it ever does. And when I say if it ever does, I mean in severe cases, like if a nerve is severed or something like that. But just due to pressure, it can definitely heal. It just takes a little bit more time than a simple strain of a muscle. It just, muscle tends to heal much better than nerve tissue does. So if you've got numbness and tingling, pins and needle sensation, weakness, anything that's a neurological type of issue that's not due to anything overly serious, doesn't mean that it will never heal. It just means that it could take a lot of time because of how hard it is to treat nerve tissue. In
your experience, though, is there more common causes of sciatica?
Yeah, I would say... I'm not sure, based on research. I don't have the research answer to that, but sciatica is often due to some type of disc herniation in the low back somewhere.
Well, that's common.
Yeah, that's pretty common. Or just tight muscles in that area. A lot of us, we don't realize we sit all day, right? And when you're sitting, you're putting pressure on that sciatic nerve. It may be getting irritated just from simply sitting, from mechanical tension of different muscles. So I would say those are the two big things that can cause sciatic nerve pain. Now, obviously, there's more serious things that can cause sciatic nerve pain, but that's not the vast majority of cases. The vast majority of cases that I personally see and that my colleagues will see where people have leg pain is often due to some type of disc pathology in the back, or even stenosis, like something affecting the spine, right? Stenosis can be pretty common too, or it's actually just muscular, which, I mean, if you had to pick any of those, muscular is obviously the best because it's going to be the easiest to treat. Disc issues will be somewhat easier to treat than obviously something like stenosis, because stenosis is potentially bony changes, which in the absence of surgically removing those bony changes is going to be very difficult. But there are things you can do to manage stenosis for sure.
Is it generally one side or both sides? Can you have, I'm by sides, I mean legs. Can you have both legs for sciatica, or is it usually one at a time?
Again, it will depend on what the underlying source is. So something like a stenosis, like a central stenosis in the spinal canal, you'll get the symptoms on both sides. Disc herniations most often tend to be on one side. So if it's due to a disc herniation, now you can have disc herniations that impinge on the central canal, and then you'll get symptoms in both legs. But the majority of disc herniation cases do tend to be what we call posterior lateral, which means they're off to one side.
Posterior or anterior, okay.
Yeah. And then muscular issues, depends. It depends if you're doing something, a certain posture that you're in, a certain way that you sit, where you favor one side versus if maybe you're putting pressure on both sides. But it could be either or, and that's the important thing. I would say in acute situations, when people come in really, really bad, when they say, I've got this excruciating leg pain, it tends to be unilateral, which means on one side. But in more chronic cases, they'll tend to come in and say, I can alternate between legs. Sometimes I feel it on this side. Sometimes I feel it on that other side. So it just really depends, I guess, is my easier answer.
Is there, as far as treatment, is it stuff where it's going to be a lot of movement involved? Like, for instance, yoga or stuff like that would treat something like that, or it depends on what it is?
Again, it depends on what it is. So there's some movements in yoga. Let's take the example of a central stenosis where there's impingement due to bony changes. Flexion of the pelvis tends to be better for that. And obviously a lot of yoga poses have flexion of the pelvis, but there's a lot of yoga poses that also go the opposite way, where you have extension, and that could potentially be aggravating for stenosis. Versus the classic disc herniations, it's the opposite. Extension is often helpful and flexion is often aggravating. So this is an issue that I see a lot of, because a lot of times people come in, and again, I would say the vast majority of healthcare practitioners, if they hear leg pain on one side, they'll the first thing that pops into all of our heads is that it's a disc herniation. If someone, though, does have underlying stenosis instead of the disc herniation, and you're treating it like a disc herniation, you may potentially be making it worse, because I just went through how one thing that's relieving in one scenario is actually aggravating in the other scenario. So that's why, what I always talk about, which is the diagnosis is the most important. I have a lot of people that call me and say, they tell me a set of symptoms and they say, what can I do? And the first thing I say is, well, we got to figure out what's causing that set of symptoms. To just be general, I think that's the disservice in healthcare, when we just clump things based on symptoms without figuring out the underlying issue, and you're only treating a symptom. Many different things can cause the same symptom. So it's very important to try to figure out the underlying issue, because in doing so, then you could be more confident in your treatment intervention and more confident in the prognostic value that it'll actually work.
We'll take a short break. 416-870-6400 star 640 on cell. You have health concerns, you have pains, bring them on. Want to hear about it and hear about from you, rather, on the phone lines. Dr. Lou's here until 1 o'clock this afternoon. By the way, info@paincarecanada.com, and to get that consultation happening anytime. 1-855-55 Dr. Lou, DRLOU, the Dr. Payne Show. Global News Radio, 640 Toronto. It is 416-870-6400 star 640 on your cell. It is 12:15. We'll get to Kathy. Hey, Kathy. Good afternoon.
Hi. How are you?
Good. What's going on with you?
I would like to ask Dr. Lou, is it okay to jog if you have kind of mild arthritis in one of your knees?
I guess my next question is, do you have any pain in your knees?
A little bit.
Okay. Again, it's a very hard, I can't give an absolute on this because I often will talk about the correlation between imaging findings and people's symptoms. Now, unfortunately, what a lot of the healthcare profession has done is that when they take an x-ray of some part of the body and they see wear and tear, which is arthritis, that's all it really is, we'll often say, oh, you have pain because you have wear and tear. The research is very clear that it's 50-50. You may have pain because of degeneration, or you may not. So what I mean by that is if we picked 100 people right now and we x-rayed their knees at random, 50% would likely have some type of mild osteoarthritis of that knee. That same 50% is not necessarily the people that have knee pain. So in your case, Kathy, first and foremost, I'd want to make sure, is the knee pain that you're experiencing related potentially to the arthritis? If we can be confident that, this seems likely that the arthritis is causing your knee pain, then I guess I would have to say that jogging is probably not one of the best activities for the knee just because of the amount of pressure that's put on it. But again, it all really depends. Is the source of the pain due to the wear and tear in the knees, or is it not? A lot of people have knee pain due to other issues. And so, the other thing with jogging is very specific in the sense that most of us don't have the ideal gait pattern. And so when we do jog, we tend to put pressure on one side or another side, different areas. And so there's also functional ways that you can work on things where you don't necessarily, some people love a certain activity like jogging, and maybe it's not most ideal for them, but maybe through other interventions like functional training or maybe an orthotic or a specialized shoe, you can help those imbalances so that it minimizes the level of pain. But I guess as a general question, should you jog if you have arthritis in your knees? My answer is it depends, and it depends on the case. For sure. So how long have you had knee pain for?
About a year. It comes and goes.
Okay, and who's told you that you have arthritis of the knees?
My doctor. I had a scan done of it, and they found spurs, a Baker's cyst.
Okay, yeah.
And I'm sorry, I forget the type of arthritis they found.
Osteoarthritis, probably?
Yeah, and on the top of the patella, a roughness.
Okay. And where exactly in the knee is your pain?
Gosh, that's hard to say. Well, sometimes it locks.
Okay.
And I have to stop and very gradually straighten it out.
Okay. Do you get any swelling?
Well, I have a Baker's cyst. I'm not sure what that is.
A Baker's cyst is often related. So the knee joint itself has most of the joints in the body are what are called synovial joints, which is kind of like the WD-40 of the human body. What can happen with degenerative arthritis in the knees is sometimes a little bit of that synovial fluid could spill out the back, and it forms a cyst called a Baker's cyst. So that is an indication that you probably do have some arthritis going on for sure. How old are you, Kathy?
54.
54. Yeah, I mean, and the pain is generalized. It's hard to say where exactly it is.
Right.
Yeah.
Right.
So, I mean, just based on those quick few things, it sounds like your pain is probably related to some of the degeneration going on. I'd also want to see the image to see how significant it is because, I mean, at 54 years old to have mild osteoarthritis in the knee, you'd expect that out of almost every 54-year-old, not just yourself. So it kind of depends on how much there is, where it is, and if it correlates. But it depends. Have you tried not running?
Yes.
And does your knee feel better?
Yes.
Yeah. So and that's another thing that I often will tell people is that you have to listen to your body. And if your body's telling you things and you do the things that it doesn't want you to do, it's going to be in pain. So if jogging is aggravating and not jogging is not aggravating, then likely jogging is an aggravating factor. So really, if you want to eliminate the source of the problem, you got to eliminate the aggravating activity. Now, that doesn't mean you can't do anything. You may want to try a different type of exercise and see if that may...
Like a recumbent bike, maybe.
A recumbent bike, or even just...
I was going to ask you that. Yeah, biking. Yeah.
Yeah, cycling happens to be very good for a lot of different issues as long as it's done properly, because it really takes... all of the pressure off the joints, right? There's no banging going on like there is with running, and people that have, significant arthritic changes in different areas of the body. Running is potentially harmful for it, especially running, I would say, on a treadmill, because
really, eh?
Well, treadmills eliminate your body's need to stabilize, and so a lot of the tiny little muscles that will help you stabilize if you were kind of running just out in a normal street are kind of eliminated with the treadmill, and so there tends to be a little bit of weakness in those stabilizing muscles that goes on.
Never heard that before.
Yeah, cool. So it depends. If you're interested, come see me, Kathy. We'll review everything, and we can kind of make a more obviously educated decision together on whether running is something that you should or should not be doing.
info@paincarecanada.com, Kathy, or 1-855-55-Dr. Lou, DRLOU. More of your phone calls, 416-870-6400, star 640 on cell. Dr. Payne Show continues. Global News Radio, 640 Toronto. 1222, Dr. Payne Show, open phone lines, 416-870-6400, star 640 on cell. Email anytime, info@paincarecanada.com. Get that consultation happening. Sometimes, as opposed to what Kathy was saying, our last caller, sometimes people have knee pain. It might be something that goes away when they jog or exercise, but then it comes back. It's kind of a rough place to be, right?
Yeah, for sure. And that's the whole thing about, again, listening to your body. It's, we get a lot of people coming through the clinic that are doing therapy that will say things like, I feel great when I'm here, but then once I go back to what I'm doing, it all comes back. If you don't remove the aggravating factor, right? If you don't, and the aggravating factor may not necessarily be something else extra that you're doing. It may be the way you're sitting at your desk, or the lack of movement that you have in your life through lack of exercise or poor diet or whatever it may be. Without removing the aggravating factor, or if that aggravating factor is still present, it really doesn't matter how much treatment you have and how good of a therapist you have working on you, because if you do something and you feel better and then you go back to whatever's aggravating your issue, well then it's going to be aggravating. And so that brings up a point where I've met people who have said that, in similar cases to what Kathy was describing, where they know the aggravating factor and then yet the therapist is still getting them to go in for treatment after treatment. But are you not doing a disservice if you don't educate your patient on potentially removing those aggravating factors? Because really, what is someone getting treatment for if that's not eliminated? And so that's often a conversation that I try to have with people. I had a person the other day, different than this, but this person has hip pain, and they were told generally just by someone on the phone that they should come see me, and that they likely thought that laser would be beneficial for their hip pain. And they just kind of said this, in passing or whatever. Maybe they had done laser therapy and found it beneficial. But again, the treatment intervention and its efficacy, how well it's going to work, really depends on what the problem is. Yep. As soon as I saw this lady, as soon as I grabbed her hip to move it around, it was clear. I didn't even have to send her for an x-ray. There was severe arthritis in that hip. There was no motion whatsoever. And so I basically told them right away, we can do all the laser therapy in the world. And then if you really want to do it, I'll have someone in my team do it for you. But it's really not going to make a difference. You have severe degenerative arthritis.
You're talking replacement.
Yeah, you're talking knee replacement. And they were so thankful that I was honest with them. Yep. And they were like, we rarely meet. They're an elderly couple, so they see a lot of different healthcare professionals. And they're like, we always feel like we're being sold on things. And we were here ready to do this laser treatment and commit to 6 or 8 weeks of this. And you're basically telling us, don't waste your money doing it. I was like, well, my job is not to look at it just from a beneficial business side, but obviously to look at it, is this even going to help? I don't mind if someone has to spend laser therapy on something that will potentially work. But I knew all that would happen with this lady was she would get all this laser therapy. She would spend the money.
She'd be out a few bucks.
Yeah, she'd be out a few bucks. It's not cheap to get these interventions done. And again, if I could justify to myself where, hey, she's going to spend that money, but after 6 weeks, she's going to feel great, then I'm just going to make that recommendation. That's my job. But if I know that she's going to feel the exact same and have zero improvement, well, why put someone through that? Right. And that brings up another question I get emailed often. Are treatments covered through OHIP? This is a question I get often. It depends. Again, my focus is not really in the beginning treatment. My focus first and foremost is doing a personalized pain assessment, figuring out exactly what is creating your issue. If the issue similar to this patient is that you likely need a hip replacement and you go see an orthopedic surgeon, then treatment is covered through OHIP, right? That's just the way it works. If in another case, like the other person that I started the show off by saying that they needed manual release of their psoas and QL to get pressure off the femoral nerve, I recommended them to see a therapist for that. That therapy is not covered through OHIP. They do have extended healthcare insurance, so they're going to take advantage of that. So it really depends. It's very, very hard for me to answer that question when someone sends me an email saying, is it covered through OHIP? Treatments may or may not be covered under OHIP, depending on the issue that we find it to be and depending on the intervention that we determine needs to be tried. And some things are covered through OHIP and some things are not. My assessment itself is not covered through OHIP. When you actually see me for an assessment, there's a fee. It's only $45, which is, I mean, nobody ever complains about the fee. But I spend a lot of time with people. I saw a few people yesterday and each got about an hour and a half time with me. And that's, I usually budget about an hour, but they were just more complicated cases. And so I don't mind taking that extra time and just getting to the bottom of things the right way.
416-870-6400, star 640 on cell to call through and ask your questions about pain if you're in or any other physical things you have you want to ask Dr. Lou about. So let's talk about that. Unnecessary treatments, I mean, whether it's done purposely or just because, whatever, treating doctor's a little overzealous about it. What do you think about that? How do you try to avoid that as much as possible?
Well, I think if you're as a consumer of healthcare, we all need to be knowledgeable to some extent, right? Now, and I'm not saying that everybody needs to have doctor level knowledge, but in general, I would say that number one, does the course of treatment sound reasonable? So if you rolled your ankle and someone is telling you need treatment for the next 3 years, that likely doesn't seem reasonable right off the bat. If someone says that you need about 3 or 4 weeks of treatment for that, I don't think you need to be a doctor to appreciate that sounds kind of realistic. So I would say number one, what is being recommended?
Right.
Number two, is this a clinic that just does one modality and one modality is the solution?
They have the miracle machine, right?
And is the solution for everything. That's another thing that I say be cognizant of. I'm not saying that modality may not work for a lot of things, but if all you've got is a hammer, everything becomes a nail. The other thing that I would say from a patient standpoint is gauge it yourself. If you've undergone the course of treatment, if someone recommended to you, hey, let's do about 4 or 5 treatments for this issue, they should give you some type of prognosis where they should say, after 5 treatments, I believe based on my diagnosis that you should likely be 80% better, right, for example. If you've gone through 6 treatments and you're 70% better, does that mean that they're wrong? No, it just, it's a ballpark, right?
Yep.
If you're undergoing treatment 6 times and there's 0 change, well, then I think you need to be reevaluated. And even more so if you undergo treatment and you're getting worse. Right? Yeah. Don't continue. And I'm not saying necessarily disappear from that person, but just have that conversation with that healthcare professional. Say, hey, I'm not getting the results that we talked about. What's going on here? We need to figure out how I get better.
You have pain concerns, health concerns, bring them on. Still got time to call through. 416-870-6400, star 640 on cell. It's a Dr. Payne Show right here. Global News Radio, 640 Toronto. It is 12:32, Dr. Payne Show, 1-855-55-Dr. Lou, DRLOU, info@paincarecanada.com to get a hold outside of show hours. Kevin, hey, good afternoon. How are you?
Hey, I'm doing great. You?
Good, brother. What's your concern?
All right, so I'm 22 years old, ex-junior hockey player, turned golfer.
Okay.
I've been experiencing lower back pain. I was in my garage one afternoon, and I was just rocking my body, swinging a wedge around, and I felt a pinch almost, and I was close to immobile for 2 days after that.
Okay.
And so I've just been doing my thing, whatever. I'm a fit guy. I work out. I do yoga, all that stuff. Mm-hmm. And I'm still experiencing it. I work a very physical job as well. I work with sheet metal. There's a lot of lifting.
Right.
It's a constant pinch. And then if I move in a certain way, it could get a lot worse, but it's always there. So
okay.
I don't know what to do about it.
Have you had it checked out?
I haven't done any imaging, no.
No, but forget imaging, but have you talked to any healthcare professional about this? Or am I the first person that you're speaking to?
You're the first guy.
Then that is the first thing you need to do. You need to give me a call when we're done the show, and we need to book an assessment and figure it out, because the reality, see, this is how chronic low back pain kind of starts. Now, I'm sure your issue is nothing major right now. It's probably, to me, it sounds like maybe it's a little bit of a disc issue, but nothing major, or maybe it's a facet joint irritation. It sounds mechanical. But the point here is that a lot of people that are young think that, okay, I've got this low back pain, it's kind of there, I'm going to do my own thing for it, I'm going to leave it. And in all honesty, Kevin, probably after about 6-8 weeks or whatever, it may very well disappear. But what's going to happen is throughout your life, because things didn't heal the right way, it's just going to start to reoccur and likely become worse and worse over time. I meet people all the time that are 50, 60 years old, and they're coming in for a really, really bad episode of back pain. And when I'm talking to them, I'll say, have you ever had back pain before? And they'll say, nah, just like the general soreness. Like when I was younger, I hurt my back, and then it got better after a few months on its own. And then every once in a while it would, you get re-aggravated, but it would always go away on its own. But this time it's so bad. Well, that's kind of the end stage, right? Like if you don't get things looked at professionally right away, that's unfortunately what can happen. So I would say the first thing you got to do, Kevin, is whether it's me or somebody else, get a healthcare professional and to look at it and figure out what's potentially going on and get the right treatment recommendations now, because that's where you can make the biggest difference on minimizing re-aggravations in the future. Now, that doesn't mean even if you did all the right things with a professional right now that you'll never experience low back pain again. It just means you minimize your chances of it being as bad or potentially getting worse.
Yeah, okay.
Okay.
That sounds good. That's pretty much my situation to a T. So,
yeah,
the next step will definitely be assessment. So,
yeah, for sure.
Yeah, all right. Well,
okay, Kevin.
Thanks for your help today.
No problem.
Yeah, like that is me exactly 24 years ago.
Yeah, and how's your back nowadays?
Still fighting it at 46.
You're still paying the price.
Yep, big time.
I've done it myself.
Oh, wait,
too.
Kevin, do it.
I've done it myself too. I've had injuries before I was a healthcare professional. When I say this, I'm not trying to be critical in that we should all know better. But that's kind of the point of why I do this show, is that people that do listen, you do know better. If you are experiencing pain and it's kind of lingering and you're not really sure and it's not that bad, don't just wait for it to disappear on its own.
Just because you have youth on your side.
Yeah,
right?
because it likely can diminish to a point where it's not noticeable. That doesn't mean it's not going to come back and cause problems later on, for sure.
416-870-6400, star 640 on cell. Hey, Graydon, how are you?
Oh, not too bad, doctor.
Hey, what's going on?
Okay, from the balls of my feet to my left buttock is numbness.
Okay.
The inside of my leg, all the way up.
Yep.
And my ankle has been swollen for over 2 weeks. I've been to see my doctor, but didn't do anything about it. Then I had to go to the Oshawa Hospital, and I had a checkup, and they called me okay, and they just gave me some antibiotic for the swelling. But numbness has been going on for quite a while. And to walk, I have to take baby steps.
Right.
To walk to my store, it took about 10 minutes. And now since I walk, it's just a little over almost half an hour to get there.
Right. And so how long has this been going on?
About a little over a year, but it wasn't as extreme as it is now. I could tolerate it before.
And so you're saying that the doctor has said that everything's okay?
Yeah.
Okay, that's the family doctor has said that?
Yes, he didn't give me any antibiotic or anything.
Well, has he sent you, here's the thing though. You went to an emergency room. The emergency room basically discharged you. That doesn't necessarily mean that everything is perfectly fine, that there's no issue. It just means that it's not an emergency. This isn't life-threatening. It's not going to, kill you within the next 24 to 48 hours. That's the job of an emergency room. It's the job of the family doctor to now manage you. And if they don't know what it is, send you to the right specialist to figure out what's going on, because you can't say that there's nothing wrong if you're experiencing this kind of pain, numbness, tingling, swelling. There's obviously something wrong. He or she just doesn't know what it is, but it's his job or her job to try to figure that out through point of contact referral or whatever it may be. Or you can take that on yourself by, doing like what you're doing right now, giving me a call. And I'm going to simply suggest you should be seeing me for an assessment, because there's clearly something there. It's just a matter of what is it that's causing it. And then once you can figure out what's causing that, then you can make the treatment recommendations that would likely help or at the very least manage the issue.
Yes, I've asked him numerous times to send me to a specialist, but he says just let it continue. It might heal itself or so.
Yeah, I mean, I'm not going to comment further on your family doctor because I don't know his or her reason for saying that. Maybe there's more to the clinical history than I know from talking to you for, 2 minutes, and there might be other things going on. But in general, it is the family doctor's job to make the referrals that are necessary. And if you're not getting that, then again, there's opportunities like the one that I'm providing where you can see me for an assessment, and we can try to figure out what's going on.
I've had CAT scans and MRIs, and I passed those tests. Well, negative on that, but
and that's good. That helps to rule out things, but it doesn't. Again, people that have low back pain will often, or like leg pain, will often say, "I had an MRI and it was normal." Well, then that just means that there's nothing in your back causing that, but that doesn't mean it can't be other things. So there's a whole bunch of things that need to be done before you can absolutely say, "Hey, we can't figure anything out." Right. And I don't. It doesn't sound like everything has been done yet.
Appreciate your call, Graydon. We'll slip you in here, Nick, before a break. What's going on with you?
Am I on?
Yes, sir.
Excellent. Yeah, question. I've had right shoulder surgery. Not surgery, more of a scope because I've had a tear in the labrum and I've had a little bit of osteoarthritis in there. But it's still painful. So the question for me is, do I go as drastic as a shoulder replacement, or do I go with non-invasive ideas such as synovial fluid? If you're familiar with that, obviously you are. I don't know. Obviously, you can't tell me personally exactly how it's going to go for me. But what's your feeling regarding synovial fluid and things like that?
Yeah. So and I think you nailed it on the head with what you just said. I obviously can't tell you what your best option is right now because I haven't assessed you. What I can say is that I do believe that people should exhaust in the absence of something that's completely debilitating that has no other option. But if this is something that you can try more conservative options for before you jump to surgery, I'm always kind of a fan. And again, this is in general. This is not me answering for you specifically. I'm just going to make a general comment here. In general, I do believe that conservative therapies should be exhausted before more invasive therapies are considered or done. Just because why jump to something like that if you can get it better with something else that's potentially not as invasive? And there's obviously a risk to anything that becomes invasive. There's risk of infection later on. There's risk of other types of nerve damages and muscle damages that can happen. So I'm just a fan of trying, and again, this is a general statement, and it very much depends on the case, but I am a fan of trying the more conservative options before ever going more invasive.
And I will, and that's probably what I was expecting to hear. My question then is, like, as far as synovial fluid goes, is it essentially like an oil in between like two pieces of steel? And I don't have that in my shoulder. Not that you can assess it.
I don't know if you're lacking synovial fluid. What I can tell you is, synovial fluid is important for joint movement. That's what lubricates the joint. It's more complex than just oil in between two pieces of metal. But the analogy is as close as we're going to get because we're living tissue. So it brings nutrients. It takes nutrients away. But it's there and it's secreted with movement. So, I'm not sure if there's something going on with you that's just preventing synovial fluid, and if it's not there and putting it there may be helpful.
Nick, appreciate that call. Everyone else, 416-870-6400 star 640 on cell. Lots of time to call in with your questions. Have them answered here by Dr. Lou. It's the Dr. Payne Show, Global News Radio, 640 Toronto. 1245, Dr. Payne Show here. 416-870-6400 star 640 on cell. Want to remind you once again, consultations. Get in there, make that phone call, right?
Yep, it's that simple. Just give me a call, and I people are really, really taking advantage of that. Leave me a voicemail.
Yep.
And name, phone number, good time to reach you back at, and just a quick little brief synopsis. Or if you want to send me an email, if that is easier, info@paincarecanada.com, and I will get back to you. Again, I think sometimes people, they'll call me or email me looking for the most specific advice. Yep. And again, the point of the email or the phone call is really for me to point you in the right direction. If the right direction happens to be come see me for an assessment, such as we've seen several times on the air right now, then that's what I'm going to recommend. Or if I think, hey, you're already doing the right things, I've spoken to people who kind of tell me, I'm in the system, I have to go see the surgeon, I'm getting this test, blah, 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 blah. And I'll just simply say, hey, you're down the right path. There's nothing really different you can do. Or, go back to your family doctor. This is not really an issue of the type of pain issues that I'll deal with. So it's just as simple as giving me a call and we have a quick discussion. There's no commitment either, right? Like I don't force anybody to do anything. Mm-hmm. If I recommend, hey, you should see me for an assessment, but you prefer to go see someone else for an assessment to get this issue sorted out, that's fine. That's not, I'm not gonna, force you, and there's no commitment, there's no fee, there's nothing. You just simply give me a call or send me an email and I will, assess it from a consultation perspective and give you what I think is the best option at that point.
416-870-6400 star 640 on cell. From a basic lifestyle point of view, this time of year, right till about the end of March, beginning of April, it's obvious people get out and start doing stuff. What do you recommend your patients do? Because it's a time of year where you can get pretty sedentary. Right?
Yeah, and I was going to say, I think the recommendation is just try to stay active as best as possible. Yeah. I mean, I know it's cold and there's things, but that it doesn't mean that every single day is freezing cold or has 15 feet of snow or something. You can still get out and walk, right? Like you may not be able to say, hey, every Monday, Wednesday, and Friday I'm going to go for a walk. You may have to be a little more fluid in that, hey, today's not a bad day, so I'm going to try right now. So I think getting out is for sure important. I think another important thing with pain levels is our biggest source of vitamin D. Vitamin D is a very, very important vitamin, is the sun. There's a lack of sun at this time of the year, right? And so maybe vitamin D supplementation. And again, I think you should always speak with your healthcare professional, whoever that may be, before you start adding supplements or things to your routine or how much of something. But I think vitamin D is an important thing. The biggest thing is just try to stay active. I also think in this time of the year when people are less active, holidays, it's easier to get out of hand with the eating, the drinking, all of those things. And remembering when we're speaking about pain, the things that you put into your body have an effect on your pain levels, for sure. Some things just promote inflammation, and in promoting inflammation, you're going to experience more pain. And so a big component of pain management is also the diet intake and minimizing certain things so that there's less of an effect on the inflammation side of the body. But keep active as best as you can, whether that's maybe you have to join some recreational leagues, sport leagues, or whatever it is. I mean, I can't
learn to skate again, like I did after 37 years.
Yeah, try different things. There's lots of winter activities that can be done, and just be careful with anything that you're doing, obviously, because you want to avoid injury. Or if you're feeling, another big thing with when people try new things, like you're saying with the skating, is something that you haven't done in a long time. You may very well go out and do it, and you start to feel like, hey, I got this left hip issue. Don't just sit there and say, oh, I'll just push through it and it should get better. If you're having a functional issue with some type of activity, just get it assessed and let's see, is it something or is it not something? Is there a way to modify the activity so that you minimize that and really go from there?
It's so funny you mention that. I know I'm not the only one with this type of thing, but I picked up skating again last year, as you said.
Yeah, I remember.
First time in 37 years I decided to try it again.
Now we know your age.
Right.
At the very least, you're 37.
Yeah. Oh, yeah, at least, right? But it's funny you mention that. Now every time I go, and I'm assuming it's going to be the same this year as last year because I haven't gone skating since last winter, but every time I'd finish just pleasure skating, going around, I would get pain at the bottom underneath my left patella. My left leg, not my right, for about 20 minutes. It'd be like, man, this is really killing me. Then it would go away. Just my left knee. After I skated that one knee for 20 minutes, then it would disappear.
20 minutes during the skate or after? Did it hurt while you were skating?
No, not really.
No, it was just after.
It was after. For 20 minutes driving home, like, oh, my knee's killing me. And then it goes away.
Yeah. I mean, you're another good example.
Right.
From a functional standpoint, a lot of the times, and I had a patient yesterday who hurt his knee. He's a pretty competitive weightlifter. And he started feeling an issue, and he did something really smart without me even telling him. He's like, I got someone to videotape what I'm doing so that you can actually see it. Right. So that's what I was going to say in your case. A lot of the times, if you're doing something or, your desk, you notice your neck pain happens more often after work and you're going to come see me, take pictures of your desk. Give me pictures of the activities that you're doing, or a video if it's something isolated like a squat or skating. The more information I can get, the more I can analyze that from a functional perspective, because, right now I can get you, John, to stand up, do different things, but we're not really ever going to, in this room right now, we're not going to mimic skating without, awesome. Without you going skating. And so a lot of the times, being as specific as possible is most important when people speak about activities. And I've done that before with high-end athletes. I'll actually go out and go assess them in their sport, because that's when they feel the issue.
Observe in their environment.
Exactly. Yeah. Very good.
416-870-6400, star 640 on cell. Still got a couple minutes to call in, have your questions answered here. Dr. Payne Show, Global News Radio, 640 Toronto. It is 12:54, last few minutes of the show here for this week. Assessments. Let's talk a little more about that. Right?
Yeah, I just wanted to touch on something as well. If you've been listening to the show for a while, a lot of people that end up coming to see me are longtime listeners. If you know that you need an assessment, because I've now said it a million times, where, if it's a musculoskeletal issue, that's kind of what I'm going to recommend. If you want to skip the step and you don't really need to leave me a voicemail to discuss the issue kind of in the form of a consultation, you just want to go straight to an assessment, when you call 1-855-55-DR-LOU, option 1 will take you to the clinic where I do the assessments, and you can just simply call them.
So option 2 is for the message?
Option 2 is for the message. Nice. Option 1 is if you just know you need an assessment. Good. Book it, and that way you're in. Because when you call me and you leave me a message, I'm going to call you back. I try to do it within 24 to 48 hours, depending on how busy I am, different cases, etc. And then I'll have to send it off and get them to call you. But again, if you just want to skip that step, if you're listening, you need an assessment, that's the next step. Just simply call, hit option 1, and that's it. It's funny, I just got an email about someone asking, is treatment covered by OHIP?
Really?
Even though we just talked about it. So again, that depends. Right? It depends. Sometimes certain treatments are not. Step 1 is the assessment is not covered by OHIP. My personalized pain assessment is just simply to figure out what's going on with you, what's creating your issue, and from there I will make a recommendation. Depending on, and I'm going to make the recommendation based on what's called evidence-based medicine. What that means is the best available research that we have, my experience, what I have seen works and doesn't work for those types of things. And another part of evidence-based medicine is what you, the patient, wants. Because, I may very well say, hey, labral tear of the hip, research supports surgery. Right. I think surgery is the best option. But if you, the patient, say, well, I don't want surgery, then we're not doing it. Yeah, you got the final call. So, and then we can look at other options that maybe don't have as good evidence-based things. But my job, first and foremost, is going to be making the best evidence-based recommendation. A lot of people that come see me, I'm a chiropractor by trade. That doesn't mean your recommendation for treatment is chiropractic. This simply means that that's my profession. I'm going to assess you from a pain perspective, and whatever the recommendation is, I'm going to follow through based on the evidence. And my team is composed of all different kinds of healthcare professionals for that reason, so that I'm not just biased to one treatment intervention.
Yeah. And by assessment, we should say it's not in and out in 10 minutes. This is
absolutely not. Yeah,
assessment.
I also had a patient yesterday who came in with his wife. He took about an hour and a half to do. And
that's deep.
Yeah. And she then said, hey, could you see me today? And I said, well, I've got another person right after that's actually already waiting for me. And after that, I do have about half an hour, 45 minutes, but then I need to run because I need to go teach. And I said, and in all honesty, I'm probably going to say it's just better for you to come back, because even though 45 minutes is a long time, I don't want to have a time limit. I don't want to have to say, hey, I got to be out by this point. And I knew at that point I would have to be out. And I was like, and I don't want to do you a disservice. I'd rather spend, the same amount of time that, if need be, that I've spent with your husband, ask all the right. I ask a lot of questions when I do a pain assessment, because it's very, very important, and it allows me to be the best detective I can to figure out what's causing the issue. And then I do a lot of different testing. I'll often repeat a lot of tests just to make sure that I'm getting the right findings. Sometimes it's not uncommon. People who have seen me, it's very common that I'll say, hey, I'm going to be right back, and I'll bring in one of my colleagues and get their opinion too. Just to figure out exactly what's going on.
We'll be back next week. I think we're doing 2 hours next week. You said, there you go. So in the meantime, 1-855-55-Dr. Lou, DRLOU, or info@paincarecanada.com. This has been the Dr. Payne Show. It's Global News Radio, 640 Toronto.